everyone, it's Dr. Gallus with Restore SD Plastic Surgery, and we're back for another round of Carpools and Cannulas. I was playing with some of the filters on here, but they're weird and make me look super fake. But let me get Dr. Greer on here, and we were going to talk about incision decisions. View request. Oh, cool. My Wi-Fi is super slow. There we go. Okay, please hold for the one and only Dr. Greer. There
Hello.
you are. Hey.
Sure.
Oh my God. Thank God someone's doing the lawn right now. So helpful.
Fantastic. You guys get me with like no makeup on because I was in the OR today and then I just got back from the barn and yeah. Mm-hmm.
Well, I feel like my lighting must be good because I have OR like nothing. I put some lipstick on.
Nice. Yeah. OR
and I was
like I'm wearing a mask. I don't know why my face is all red. Just ignore that, everyone.
You're just sensitive.
I am. Actually, my skin gets so red so easily. Oh,
cool.
That's why I love the Illumia, the Calm R serum is awesome.
Yeah. A couple of girls in my office use it because they have sensitive skin.
Yeah, but it's also the only retinol I can actually use without my skin freaking out.
Nice. Yeah, I do like their stuff. Hey, Quinn, how's it going? Oh, you have a cat. My dog is behind me.
Yeah, he also will like knock over plants while I'm on calls too. It's very helpful.
Cool. Well, I'm excited about this topic because somebody actually called the office and was asking about tummy tucks. And then was like, how does Dr. Gallus close the incision? And I thought...
You're like, I have a whole Instagram live coming up. Just you wait.
Yeah. She should tune in and hear. I think she wanted to know specifically the number of layers that I closed in. So I figure she must have gone to a consult where somebody made that a selling point. I don't know.
It is interesting, though. Like, you kind of forget that not everybody does everything the way we do it. Like, I remember being on my gyne surgery rotation and they were just throwing some random sutures in the fat. Not like scarpas, not like dermis, just some fat. I'm like, huh.
Yeah,
that layer.
Yeah, they do close things differently and usually get away with it. So, and no one's like coming back and complaining about their C-section scar, right? I mean, they are, but
they heal beautifully.
Yeah, for the most part. So yeah, I do think most plastic surgeons close in layers, which means from deep to more superficial. And then yet we're always trying to find the most efficient way of closing. So
right. Because that, I mean, if you think about it, we open and we close. Like that's the whole surgery. It's a lot of suturing. It is though. I mean, plastics is kind of funny that way. But and especially I work at a surgery center where the assists don't close. They just retract. So
yeah, same. In California, it's actually, you're not supposed to have scrub techs suture for you. And yeah, so although, again, I'm aware of some places where that happens, I'm kind of a rule follower, so I do all my closing.
My cat is literally licking the screen like 2 feet from my face, and stop. It's loud. So weird.
Not as loud as the lawn stuff.
Fair enough.
So, yeah, I remember being a resident and we did a huge body contouring case, the kind you could do when you have multiple people operating. So I feel like it was a paniculectomy and maybe a thigh lift and maybe something on the chest. It was this pretty large man. And we stapled everything closed and it was the end of a long day because we were tailor tacking, which I think we should explain in a second. Mm-hmm. But basically you staple the skin closed. And then anesthesia, the resident was like, oh, wow, you guys are done? And we're like, oh, nope, we're just closing. That's actually the operation is going to be closing.
It takes forever. Although it's funny because you think about it, like I remember having 3 residents close on a breast reduction one time. And it's like, how do you all fit in there? And I think you slow each other down.
Yeah.
And me with somebody following me, and we'll explain what following means, and cutting my sutures like so much faster.
Exactly. So, all right. So why don't you explain to everybody what tailor tacking is?
So tailor tacking, I mean, it's just like you're tailoring, because a lot of what we're doing is tailoring skin, especially in patients who have lost a ton of weight. We're literally like tailoring it to them. So what people do is you'll kind of tuck the skin and staple it in place and then mark it and then trim it. And it's a bit of a process. And that's one of the areas where you really can gain a lot of efficiency when you, all my patients are on here tonight. You guys are awesome. That is one of the areas where I've gained a lot of efficiency by not doing it as much. Like just drawing the marks, trimming the skin, and not tailor tacking and marking everything and then taking all the staples out and trimming it.
Right. So yeah, I would say I don't do it in every operation. There's certainly like revision breast surgery, I almost always have to, right? Because I get in there and you get whatever implant was out, and then you're not sure what you're going to have once you take the capsule out and all of those things. But I do remember doing that for breast reductions, and for the most part, you don't need to. If you
kind of learn like how to eyeball it more,
what's going to work, right? But
yeah, even for my sorry, go ahead.
It's helpful to pull the skin together. You use a skin stapler. Make sure it looks like you want it to look, mark everything, take the staples out, and then you close in layers, which is the actual closure, and it takes a minute. So
especially, those massive weight loss patients, I've measured the length of incisions just for fun, and sometimes it's like 6 linear feet of incisions we're closing by ourselves, and I get a little callus on my thumb from the needle driver right here. My thumb hurts at the end of the day because it's a lot of work.
Again, you have sensitive skin.
I'm a delicate flower.
That's right. That's right.
Yeah. Mm-hmm. So I keep telling people.
That's why you have the needle driver tattooed on your arm, right?
Yes. Oh, here, I'll show it again, because you guys know I love showing off tattoos. And this is life size, actually. This is about the size of the Webster needle driver I use. But I think the needle's loaded like a little bit too far back. I was very picky. I was like, you don't have it loaded right. He's like, well, that's what you get. Yeah, so this is what we used to suture, by the way. I have a very miniature one on my keychain. It's so cute. I've had it for years. Yeah, and you try not to stick your fingers all the way through the hole, so like your fingertips are resting on it, because you have to really be able to rotate your wrist. That's the key to suturing with those curved needles. And I just remember the plastics attendings harping on all of the other off-service rotators like neurosurgery and general surgery. They're like, supinate your hand. You got to rotate the wrist.
Yes, rotate the wrist. That is part of the game. And then I'm left-handed, so you have to learn to open and close the needle driver with your left hand.
I'm not sorry that you're left-handed. It's just that left-handed instruments. So have you guys ever tried to cut with scissors? If you're left-handed, it's super hard because the leverage on the blades, you're not pushing them together. When you use your left hand, you're pulling them apart. So you have to cut differently, and the needle drivers open and close differently. And yes, they do make special left-handed instruments, but since no hospital ever has them, it's not like you learn with them when you train.
Right. So I had a partner in the Navy who was excited, and when we arrived, got a set of left-handed instruments, because me and the other attending that started were left-handed, so there were going to be 3 left-handed surgeons. And I was like, I don't know that that's going to work, because we've spent a decade learning with the right-handed instruments. So
it's like trying to write with the opposite hand, or like my brother's trying to play left-handed golf. He is left-handed. He just learned on right-handed clubs.
Yeah, it was terrible. We didn't use them. I was like, you feel like you're having to start all over again.
Oh,
so I was like, hard pass. I don't have special. And like, who needs to be that much of a diva and have your own instruments all the time? Nobody got time for that.
You know that's like plastic surgeons by definition, right?
Well, we're diva, but there's an extra level. It's a bell curve.
Fair enough, but God, this can't. I mean, like, Gyron made his own like chin retractor thing. He's like, give me my retractor. All right.
Yes, people do love to have a retractor named after them.
Because it's fancy. Whereas I'm like, do we have, what's that clampy thing? I'll use it. It's fine.
Yes. Yeah, the Navy.
Yes. Thank you, Joel. That is my Allergan rep. I do, actually, so the gold, because I'm always asking for the gold-handled Adsons. They're gold-handled marks that they have a different, pickup surface. They're like tungsten carbide. They're firmer.
Yeah, so
it's like a better instrument quality.
100%.
Yeah. Yeah. So with the needle drivers, the gold handled signals that they have a tungsten carbide platform that lasts longer, and the gold handled Adsons are finer tips. So they're just
and
different.
Just a superior product, period, honestly.
Yeah. I mean, I use the goldies all the time. So you're right. I am a diva, kind of. But they do.
So, no, I like nice. The gold handled stuff. So, all right. So before we get into the nitty gritty of how to close in layers, how about have you ever used like an alternative system to close that's supposed to be faster and then didn't work? Because I definitely have.
You mean like resorbable staples or anything?
Yeah, Absorb.
I remember the first time I used quill suture in residency, and we were like, we don't get it. But I think when you're in residency, you put so let me explain interrupted versus running suture so this makes sense for you all. Interrupted, you put in a stitch, you tie it off. You put in a stitch, you tie it off. So it's like lots of individual stitches. Running, it's like a baseball stitch or a whip stitch. So
you just
we would do all the interrupted buried dermal vicryls, and then we'd come through with the quill, and then we'd come through with the monocryl. So we're just like adding a step, and the key is you really have to put in almost no dermal sutures and run the quill, and then you're good.
Right, which was the argument for Dermabond as well.
Yeah, so, except if you don't close the deep layers, they go, which, what are you doing? Oh, he's trying to log onto my computer now. Yeah, so that's another important point of why we close in layers. You have to evert the wound edges a little bit, or those layers will separate, and then you end up with a depressed scar, which is not the goal.
Exactly. So they're kind of invented to either speed it along or ideally to improve the incision, like how the incision heals, right? And so Absorb, one of the surgeons that I worked with when I joined, then as a brand new attending, used them. So then, of course, the techs are all like, you want to try it? You want to try it? And it's basically a subcutaneous plastic staple that you put in, and it everts the skin and it lives under the skin. The thing is, it's a little bit bulky, and then if it sticks out at all or doesn't dissolve quick enough, you're picking like basically little plastic bits out of the incision forever, which has to do with the choice of suture you use. So I was not a fan of the Absorb. I think we know Deb White, who practices in Phoenix, I think Phoenix or Scottsdale.
I think Scottsdale. But yeah.
She really likes them, but I think they've been kind of revamped since then, and in the right patient, it can be helpful, I guess. But yeah, that was my take on that. Quill suture, I think, is nice, but it needs to replace a layer. It can't add another layer. So if you can run a layer, you use them don't you use some version of that for your drainless tummy tucks, right?
Yeah, I use Stratifix.
Okay.
It's
a barbed suture.
So they're barbed. They have little barbs, and the idea behind that is you run it, and if part of it breaks, the rest of it stays in place, which is why it can replace all those deep dermal sutures. So I started using Stratifix actually in my breast reductions several years ago. And the key to being really fast with that is very minimal deep dermals, just to line it up, or you can even do staples. And then instead of running a monocryl subcuticular, which is right under the top layer of the skin, instead of running that, I use Prineo, which is a skin glue product. Right. So the Prineo is technically the final layer. That, I think that cut 30 minutes off my breast reductions, which at that point were like 3 hours. So that's a good chunk of time.
Yeah. And I do like the Prineo tape as well. Those are other shortcuts. So that's Dermabond glue, but in a tape format. So the tape is sticky, put it on, and then you activate it. The only reason I don't use that very often is it's expensive. And if you have an allergic reaction to it, it's just miserable for people. And I feel like there weren't many, and now there's more frequent reactions. Your cat.
It's like, maybe I should have fed him before we came out. I have only had, I want to say, like 2 patients with allergic reactions, but I will say it sticks to itself. So if you do like a brachioplasty and it's in the axilla at all in the arm, your arm will stick to itself, and under the breast crease, it sticks to itself. So it's a little annoying for people, but I love that it stays on for a month and they don't have to do anything. We have there's another plastic surgeon who uses it just as a dressing, so it like saves no time.
Yeah, that's how I used it. I know. So, right. So it's just extra cost. Can the last absorbable suture be ripped off? No, not
well. If it's under the skin, then no. I mean, if you use like a fast gut suture on top, then yeah. But
yes, and I do think that these are things I don't think of. Hi, Paula. But even my patient today was asking as she was going to sleep, was asking, like, she was already nervous about having her sutures removed after surgery. And I was like, what sutures? There are no sutures to remove. They're all going to be dissolvable and under your skin. So yeah, I think people assume that there's going to be something to take out, and most of us close without anything to take out down the road.
It takes time and it hurts and it's not fun. The only non-dissolvable sutures I use are when I make a new umbilicus for fleur-de-lis abdominoplasty. There's 3 nylon sutures in there, and my nurse Tana gets to dig them out. She loves it.
Right. That's the other thing. Don't put them in if you're not willing to get them out later.
Yeah. I know a lot of people will do permanents on facelifts, and I just never wanted to.
I did them here and there, like in certain areas. And I'm like, why am I? And the same thing, actually, when I was in training, we did a lot of cleft lips, and the cleft lips we closed with nylon sutures. And
you're talking about babies? Oh,
we had to bring them back, but they had a whole system in place. We'd bring them back. This is how old I am. And then they put them to sleep for a second, and so back to the OR, and then we would take the sutures out. And then eventually we're like, why aren't we using, so we used Dermabond or whatever the equivalent was, and then absorbable sutures. And it does look like they have little snot, crusty noses, but
so what?
You're done. Like,
I know. I hate taking sutures out. I used to do, on my bleps, I would do like a pull out Prolene, but it hurts pulling that out. So now I do that, then I glue it, and then I pull out the Prolene before the patient's awake.
Nice. Yeah, I was doing the pull out Prolene too, and nobody likes it, or the Prolene breaks, and then it's just
awful. And it breaks, and that's miserable. You're like, it'll come out in like 3 months. It's fine.
And 15 office visits as each little piece circulates. Ugh. I know. I'm like, what? I feel like there's somebody who pulls them out on Instagram all the time, and I'm like, no.
Reasonable.
Yeah. If it's not your eyelid.
And like, we never staple things either, by the way. Although in residency, it was actually our chairman. He would staple paniculectomies, and very large breast reductions he would staple.
No.
Yes. Yes. And he's like, the scar heals the same. And then we'd rotate with the cosmetic practice across town, and they're like, no, they all come here for revision. Mm-hmm.
Oof. Yeah, it doesn't. So then you end up with something called we call them train tracks, right? Because as the incision heals, you can see each of the little points on either side of the incision where the staple was, little dents.
I almost had track marks, and then I remember that's something different.
That is a problem in Ohio, I've heard, but
I'm pretty sure it's a problem in California too, Kat, but
but
you get the little train track marks. Mm-hmm. And that's why we don't use permanent sutures either. If you do, use very, very fine ones. But then, like, I've seen ortho, they'll use like monocryl outside the skin, which dissolves, but it takes plenty long enough to leave little suture marks.
Yeah, you have to take that out.
Yeah, so stitches all dissolve at different rates, by the way. And when you're a surgery resident, it's really fun learning all the different sutures, because there's monofilament, which are kind of like fishing line, and then there's braided, which are more like string, but then there's different monofilaments that last different lengths of time. In the braided, there's arguments about whether you should use those in dirty wounds. And honestly, it does matter. Like when I used Stratifix first, I was having a problem with it spitting all the time, and I was using a 3.0 PDS Stratifix, so I switched to a 4.0 monocryl so it dissolves faster.
Right.
Yeah.
So, the suture's gonna hold. Oh, sorry. Go ahead.
I was going to say the sizes of suture. That's another fun thing to talk about, because they come in different sizes. O is the biggest, then 1.0, 2.0, 3.0. I don't know how they came up with the names, but it actually measures tensile strength, not the diameter of the suture, which is thing, and something you get pimped on when you're in med school.
Right. Yes. And then it goes all the way down to 9.0, which you technically barely can see, just under the microscope. So, and there's a 10.0 too, actually, but I've only ever used 9.0 under the microscope because
you can't see it.
It's so painful. Yeah. Because the poor tech is trying to hand you, and you feel like you're the emperor's new clothes. They're like trying to load and hand you.
And there's nothing there. Yeah.
Suture, and you're like, you get under the microscope and you're like, there's nothing here. Like, you didn't hand me anything because you can't see it. Sorry. But yes, so there's different types of suture. Again, when I was in training and did a lot of county hospital facial lacerations, I would say the gold standard is to close with a suture that isn't going to absorb, and you have the patient come back in 3 to 5 days to have it removed from the face because you don't want to leave any marks. But people consistently didn't come back, so we closed with suture that was going to absorb and fall out, either a chromic or fast absorbing, because people came back with like the X fixes in their hands and stuff stuck on, like
like a month, 2 months later. Yeah. I always use fast gut or chromic if it's in mucosa, because again, they don't come back, or they come back in like 2 weeks and then it looks terrible.
It's too late. Yeah.
Absorbable suture was a wonderful invention. Also, the fact that, suture itself, because they used to use horsehair to close cleft lips, like from horse tails. Like, I remember the older attendings, again, same chairman in St. Louis, his dad started the program there, and like they would go to Forest Park and pluck like hair from the tails of the police horses, and they had some of it like in our library.
That's crazy. Well, also cat gut, gut suture is made from gut. Like,
what is it? The propria of the small intestine. Why do I know that? Where does that stuff come from in my
I don't know. You're like a suture savant.
Apparently. I do have a passion for suturing. I mean, you don't go into plastics if you don't like suturing.
No, it would be a no-go. I know. It's so like, I don't knit, but I imagine it's a little bit like knitting in terms of like, you're just kind of in your groove and you close and you're just like, I'm going to, so
it is a lot like
perfectly and everything's pretty. So yeah. So do you generally, let's say tummy tucks, do you close in 3 layers or 2 layers, or what's your deal?
I do close in 3 layers. So I do scarpas, fascia, which is, you have superficial fat and deep fat, and they're divided by a fascia layer, which is actually fairly tough and will hold stitches. So we like to do that. So I'll close scarpas, then deep dermis. Although, and then skin with perineo. But I switched. I used to use interrupted 2.0 Vicryl to close scarpa. And now since I do progressive tension sutures, like down the abdomen with the 2.0 Stratifix, then I just run along the scarpas. Yeah, it's great. It's so fast. And the other thing I love about it is you can kind of adjust the tension. So you run it and there's weird little puckers and you just pull on the tissue and it kind of settles right out.
Yeah, that's nice. Yeah, I close in 3 layers too. I'll sometimes do 2.0 Vicryl for the deep layer, like you talked, and then sometimes I'll run the deep dermal instead of interrupted, because it's, if everything's laying together really nice and it just holds it. And then I did use Stratifix or Quill or one of those versions for the deep dermal at some point, but I had spitting problems. Nothing's worse than having, the suture react. And then monocryl. And then I just do steri strips. The place I'm at now doesn't do Dermabond. It's nice, but I've decided that it doesn't, now that I'm used to not using it, I'm not sure I really need it. And the one in however many allergic reactions that you get is annoying. So
I'm thinking, who is it? Betsy, why am I not?
With Durazorb. Somebody said the first case with Durazorb.
Oh, Durazorb. Are those are like the Insorb staples, Joel? I think. Oh, but Betsy Hall Finley just uses the brown paper tape. Like, that's all she uses on all incisions.
Yeah, I use.
It stays on for like a month if they leave it.
It does. No Mastisol. If it's clean and dry when you put it on. I think if you're going to use Dermabond, it makes sense to.
Knitted mat. What is that for? Like, is that kind of like a Galaflex product? Like a resorbable mesh, which I use Galaflex again today. It's so fun. I like it.
I used it the other week since remember I texted you.
Yeah, you did. I'm like, here's what I do.
Because I was like, I don't want to have to do a different pedicle. And you're like, no. Yeah, no. I was like, perfect. It's nice that we have the same style.
Oh,
yeah.
Yeah. No, I've always used Galaflex. I haven't tried Durazorb. Is Durazorb?
Oh yeah, I've heard about it, but I haven't tried it.
Yeah, I'm liking Galaflex. You just have to get over that, like, first 6 months where it feels like, you know, the dog toys where they have crackly paper inside? It kind of reminds me of that because you can feel it a little bit and then it resorbs and it's great. Oh, so the horsehair sutures, that was making me think of the nurses used to have to thread the needles too back in the day. Like there was a hole in the needle and they had to like thread the suture through it, but now it's swedged on, meaning it's just fastened to the needle and they come out of packets. So
yeah, I do think the stapler helped speed up burn surgery.
Oh my gosh.
Because you had to staple the casts on, and when I was there, they're like, oh, not that long ago we had to suture everything in place. And I was like, oh God. You'd be there forever. Patient's sick. So you need to go. Yeah.
And the nurses would be taking out the staples for ages in the burn unit.
But
there's like hundreds of them.
Yes, I know. Yeah. So, the only other thing I'm going to add about suture is that depending on the type, monofilament or braided, it has to do with, it creates an inflammatory process, which you want the suture to do. That helps, right? You want it to last long enough for your body to like heal and form a strong enough wound that when the suture is gone, it's, you know, stays knitted together essentially. Right. But I found I had an old partner that would close the deep dermal with 3/0 Vicryl, and I feel like it was inflammatory and it would spit suture. So trying to find something that lasted the length of time you needed. And so most people, I think, close with 3/0 monocryl because of that. So
I actually use 3/0 Vicryl.
You do?
I do. Not very many of them, but
a few. Or
for the deep dermal, yeah. And then I do the 4/0 Stratifix. But yeah, I've always done a lot of 3/0 Vicryl. I've only had a couple spit. I mean, once or twice I'll spit. I do have one patient who literally cannot dissolve any sutures. Like, yeah. Because some people can't. Like, they don't, there's a particular enzyme or something that breaks them down. And she literally spits everything. It's amazing.
Yeah, or they get an over-inflammatory reaction. So yeah, spitting suture is your body like trying to ward it off like a foreign body reaction instead of just doing its healing thing and letting the suture dissolve and breaking it down slowly. So instead of breaking it down, it starts to form like scar around it, and
you get like a little pimple. It looks like a pimple and it erupts and little pus comes out, and then people text you panicking because there's pus and you're like, it's totally fine.
Yeah, let me just get that knot out for you. Yeah.
Yep.
So that's the breakdown. Close in layers would be the motto.
Yep. Close in layers and evert the tissue because it will settle as it heals.
That's right. It does settle. A lot of times we're closing things that, I mean, we're not cutting a straight line and then reclosing it. So a lot of times we're working one end in, and so that can look gathered, if you will. And we all know that will stretch out as well. So that's like a
bunching, like around the nipple, you'll see that a lot, or under the breast. That's areas where it bunches and it settles out. It's amazing.
Yeah. It works out. Yeah.
Yeah. But it's amazing because like I'll see a laceration that was closed in the emergency room, and like say it'll be this long and there'll be like 4 permanent sutures in it just on the outside, and you're like, man, I would have had like 6 buried sutures and probably like 8 on the skin surface. I swear plastic surgeons use like 3 times as many, 3 times as many sutures as anyone else.
Yeah. But I do think just putting them at the superficial level, you're not offering any strength to that tissue. So it makes sense that deep sutures are going to kind of hold it together. And then really the superficial layer is just getting the edges to touch without any tension. It's all about tension. Yeah.
Yep. How did you practice when you were a resident? What did you practice on? Like people get pig feet. I like to practice on banana skins to at least practice my spacing, because then you get a little black dot where the suture goes through, so you can see how well out you are.
Cute. Yeah, we did I'm trying to think. Maybe orange skin. I feel like there are little models we could use to suture.
Yeah,
I
they
was
do.
more obsessed with tying knots than anything else. Not
yeah.
tying. So that was
like we instrument tie so much.
I know this was in general surgery. I had no idea it wasn't going to pay off later, but
yeah, only for like the 2.0 and up. It's funny. Otherwise,
but I can secure a chest tube like no one's business.
I mean, that's a really critical skill. Those are important.
Right. That is some mad skills. If I do need to use my hands instead of an instrument to tie, I'm there for you.
I mean,
but oh, and actually, speaking of left, I don't know if it's a left-handed. It isn't a left-handed thing, but I do love the Olsenhager needle drivers. If I was going to get a tattoo of a needle.
Oh, that cut? Really?
Yeah.
I never got into those because I always accidentally cut myself. Like I'd cut my stitch.
Yeah. We got to use them in plastic surgery training. And if you cut your suture, they took them away from you. So you learn quickly not to. But yeah, I freaking love those. And again, the place I currently operate at doesn't have them, but it takes me a while to readjust when they don't, because I like try to cut with the needle driver and the tech's like, what are you doing?
See, I'm such a diva, I don't even cut my own stitches. Because since my assist is right there and they can't suture, they cut for me. And then I'll sit there sometimes. I'm like waiting for somebody to cut. Meanwhile, the scissors are like 2 inches from my hand. And I'm like, anyone?
Yeah, see, I'm just not, I'd rather just do, I'm like not patient enough. Because if they like lose focus for a second, they're not right there to cut it. So I'm like, we're done.
You know, my normal scrub and assist, like my scrub is like a surgeon whisperer, because I'll like pause and look up and she's like, Dr. Greer needs a chair. I'm like, I do. I mean, yeah. And then one day I was doing a breast dog and I like reached out my hand, said nothing, and she gave me the Bovie. And I was like, how do you know if I need the Bovie or the suction? And she's like, you stare at it longer when you need the Bovie. And you feel at your head. I'm like, that is creepy, Brittany. She's awesome. I love her.
That's great. I think when you work with the same people over and over again, it is really nice when they're like, hey, do you want us to, like, there's another place I operate where the nurse is like never idle and she's constantly readjusting the lights. Like, so you don't have to reach up and do it. She'll just look at it and be like, it'd be better this way. It's just amazing. Yeah.
I know. I get so spoiled and then I'll work with somebody I haven't worked with and I'm like, I have to think.
I know.
Like no, I just want to hold out my hand and you're going to give me what I need next. Yeah, I'm very thrilled. I love it.
It's nice to get that rhythm with people. It really
is. It's fun. It's like dancing and you all know the steps.
Yeah, for sure.
Cool. Well, wow, that was actually, we had a lot to talk about there.
I know, just on suture. We'll have to think of something else equally mundane but fascinating to us to hash out for the next
Maybe like post-operative garments. We haven't talked about that.
Yeah. Yes, we could talk about that for sure.
Yeah, too bad we can't get, I think Elizabeth's last Lee never uses them. We should like have her join us.
Yeah, and that's why they're a waste of time.
Yes.
The third person. All right, cool. Well, have a good rest of your evening.
Thanks, you too.
I'm going to go gather people from ballet and soccer, etc., etc.
I'm going to feed my cat because he's clearly starving to death. Yeah.
All right, cool. All right, post-operative swelling and garments. All right, well, I think that's our winner. Yes.
Perfect. And then we can always talk about scars next time, especially.
Yes, and scarring and yes.
All good topics.
Pigments. Yeah, thanks, Paula. That's a good one too. All right.
All right. See you later.
Okay, bye.